Good morning, everyone. We are on 9th of May. We are welcome to the CMAAO meeting. This is the 57th meeting. Uh, uh, I would like to invite Dr. Chong, in absence of Dr. KK Agarwal, to chair this meeting, and we also have a special guest, Dr. Monica, for a presentation on hospital therapies. Over to Dr. Chong for chairing this meeting and inviting everyone for the comments. Thank you so much.
Thank you, Sarab, and welcome everyone to our weekly Zoom meeting, where we've been talking for 57 weeks straight on the COVID and all related matters related to this pandemic. And today we are very fortunate to have, today Dr. Agarwal isn't with us this is the second week he hasn't been with us. He's not been well, so our thoughts and prayers are with him. And we look forward to him coming back to join us soonest. And today I also like to welcome Dr. Monica Vasudev, who is going to give us a really good update on what's happening in the treatment of COVID and what's current and so on. Thank you all for tuning in as usual. And I'll hand the screen now over to Dr. Vasudev. Monica, thank you very much.
Thank you so much, Dr. Chong. I want to explain the basis as to why I'm doing this presentation. With Dr. KK Agarwal being hospitalized and being sick, we're working with patients now across the globe. And we're dealing with a rapidly evolving virus and rapidly evolving therapies to address this virus. The names of the medications keep changing. The media presenting information related to these therapies are difficult to understand in real time. And we're all part of incredible discussions through various social media groups to understand. So what I wanted to do today is to just review the basics of hospital-based, more severe COVID-related therapies. And my apologies if I don't know a lot about each specific drug. I try to put this together in such a way to even reflect that this is all new information. So today I'd like to talk about hospital-based therapies. So in terms of defining severity, that lets us know if the patient is eligible for a hospital bed. But as everyone is aware, bed allotment is very, very difficult. It's a commodity that's not meeting the needs of its citizens. And disease severity is not necessarily going to equate with a patient being hospitalized. So taking a step back from the hospital versus non-hospital view, let's talk about what the disease severity is. And defining disease severity here is mild as someone who has a fever, malaise, cough, URI symptoms, upper respiratory infection symptoms in the absence of dyspnea. When you start having symptoms of dyspnea, then you'd start getting defined as being moderate or severe. Whereas severe is defined as those with hypoxia with a pulse ox of less than 94% on room air and need for oxygenation or ventilatory support in case that pulse ox doesn't necessarily equate with that. So in severe disease, we're seeing that the management recommendations are rapidly evolving. What the recommendation was, say, mid-March is definitely not going to be what's happening in the first week of May. It's very important that what I say should always be modified using local protocols and guidance. This is only meant to be just a general summary. When we have our hospital patients, in addition to the medical management, we are monitoring our patients. There's guidelines regarding how we measure a CBC with differential, a complete metabolic panel, creatinine kinase. We're looking for inflammatory markers, CRP and ferritin. We're looking at procalcitonin. We may or may not get that every day or every other day. We're looking at a prothrombin time, a D-dimer. We're looking at a cytokine storm marker of IL-6. We're looking for acute phase reactants, again, like the ferritin. We also have LDH. We're looking for markers of myocardial injury with troponin and EKG. And then we can't forget the utilization of radiographic chest x-ray, CT scans, and looking for secondary infections such as sputum culture and sensitivity, but also looking for blood cultures as well. And this is just a beginning list. It's not exhaustive, but I'm sure most of these parameters are familiar to you as you review data from hospitalized or severe patients. So when talking about therapy, I think this is the biggest therapy that we have, and it's the one that's making the news in terms of not having sufficient supply, and it's really hitting the media, and that's oxygen. Our oxygen target is 92 to 96%. If the patient is a carbon dioxide retainer, then we're aiming for 88 to 92%, so as we're not decreasing their respiratory drive. You can use a nasal cannula of 6 liters per minute, non-humidified, low flow. You can use a Venturi or non-rebreather mask with an FiO2 of up to 0.5 or 10 liters per minute. If no relief, you can then escalate therapy to high flow nasal cannula oxygen. You can use non-invasive ventilation such as BiPAP. And then what is not desired, but if needed, is endotracheal intubation. And as you remember at the beginning of the pandemic, especially from around the globe, when we heard of many people intubating and the people who intubated got infected due to aerosolization of the virus, many of the people who intubated were also getting sick. So we are in a much better position now of realizing the risks for intubation. Avoid fans and nebulized therapy due to the risk of aerosolization. In my clinic, we do a lot of asthma care. We do not provide nebulized therapy. We've not done so since March of 2020. And maintenance of targets for oxygen therapy. In adults, you're looking for a target of 92 to 96%. In non-pregnant, again, 88 to 92 if they retain carbon dioxide. For pregnant patients, you're looking for 92 to 95. And in children, you're looking for greater than 94% or more during resuscitation, and they can handle a little bit of a lower oxygen level of 90% once stable. So it's just nice to know kind of what the recommended guidelines are. And just to for a disclaimer, I got this information from UpToDate. This is information about what is a low flow device and a high flow device. We use these terms very commonly. It's just nice to have a review again of why we use these terms. So a low flow device is somebody's normal physiological inspiratory flow that exceeds the flow rate of the oxygen that is being delivered. So that means that the patient is able to then inhale ambient air. Whereas in high flow oxygen devices, what's happening is that the flow rate of the oxygen is equal to or exceeds the person's baseline inspiratory flow rate. And therefore you have what's known as entrainment of room air is minimal or negligible. So that is the difference between low flow and high flow. In terms of what are the low flow devices, you have the nasal cannula, which is your first step. You have the parameters that can be set for 1 to 6 liters per minute. Your FiO2 is ranges 24 to 44%. And to avoid mucosal irritation, you're humidifying the oxygen. A shovel mask is used that is similar to a nasal cannula that is used for humidifying oxygen. A simple face mask sets the parameter flow rate to 6 to 10. It has the FiO2 of 40 to 60%. And then the non-rebreather is very recognizable. You have 6 to 15, you have an oxygen reservoir, plus you have the oxygen delivery. And it's a one-way valve through which the patient is expiring to reduce the rebreathing of O2, or carbon dioxide, sorry. So this is just kind of a simple overview. In terms of the high flow nasal cannula, what you're seeing here is that you have a flow rate that's much, much higher, 10 to 60 liters per minute. The desired FiO2 is higher of 24 to 100%. And it is possible that there is theoretical aerosolization with this. The Venturi mask is a flow rate of 100% of oxygen of 1 to 15 liters per minute. The flow rate to the patient is much greater. It includes a significant fraction of entrained ambient air as well. And so this is the device that you can see on the right. Non-medicated methods that can be used in the severe, even mild. This has been a part of many public messaging efforts, and that's utilization of the prone position. And especially when oxygen or supplemental oxygen is at a premium. So as you can see here, this is a very simple diagram to show you how you are able to recruit alveoli by being in the prone position in the right side of the diagram by virtue of the actual physiological and anatomical properties of our lungs. So in the left, you're supine, you're not able to recruit as much alveoli, and in the right diagram, you are prone. In prone positions for moderate to severe ARDS, it's easy to administer intervention that may improve oxygenation to those who can tolerate it. This is easier said than done for our patients who are dyspneic. Okay, so let's move on to dexamethasone. So dexamethasone is a recommended COVID-19 therapy for moderate to severe COVID patients, not in the mild patients. The dose that's recommended is dexamethasone, 6 milligrams daily for 10 days or until discharge. The equivalence of dexamethasone, if it's not available, is hydrocortisone, 150 milligrams, methylprednisolone, 32 milligrams, or prednisone, 40 milligrams. And this is from a study in the New England Journal of Medicine that looked at the original studies looking at the use of dexamethasone. And what you're finding here is that there was a study that looked at 2,104 people in the study arm who received 6 milligrams once daily for up to 10 days, plus usual care versus 4,321 who received usual care alone. And the primary endpoint outcome in all participants was looking at mortality from all cause over a 28-day period. And you can see that those who received dexamethasone, that there was an improvement in the survival rate. And they looked at secondary endpoints as well. That is well publicized. They actually have the New England has a beautiful video that summarizes these results. And this is the basis as to why we're recommending systemic steroids in our patients with moderate to severe disease. I know I'm going through this really fast, but at least it kind of gives you some visual cues as to how to follow up on the data on your own. So let's talk about the use of anticoagulation. And I know that anticoagulation is rampant in terms of mild disease, but what's happening here is that you are seeing that in the physiology of the COVID-19 disease, that thrombosis is a prominent feature. 5 to 30% who have COVID-19, so this is not just SARS-CoV-2 infection, this is COVID-19 disease, they develop thrombosis. There have been both venous and arterial events which have been reported. And the thought is that microthrombosis may be a key mediator of COVID-19 related organ dysfunction, morbidity, and mortality. And that this is one of the reasons that we are measuring a D-dimer, which is associated with increased mortality and thrombosis. So they looked at pooled data from multiple studies, and you can see those studies on the right, the ATTACC, the REMAP-CAP, and the ACTIV-4. And what they did was they looked at therapeutic dose, low molecular weight heparin, with usual dose, prophylaxis dose, low molecular weight heparin in patients with severe COVID-19 in an ICU setting. So severe patients, ICU setting, this is not your outpatient. So they were comparing those with therapeutic versus prophylactic dose. What they found in this study, when they looked at the initial pooled data analysis in December 21st of 2020, that the therapeutic doses did not appear to confer any benefit in terms of days free from organ support. And it did not appear to reduce thrombotic events or mortality. And if anything, it was associated with more major bleeding. When they continued to collect data and they looked at the same pooled data from the same studies, however, now on January 21st, 2021, they're now showing that there's a clinical benefit of therapeutic dosing. So not the prophylactic dose, the therapeutic dosing with patients with moderate to severe COVID-19 were not managed in an ICU setting by reducing the number of days that patients required organ support. So if we go back to the original data as to why are we using the medicines that we have and what is it that the actual study showed, we're seeing that there's fine kind of variations in the patients that were benefiting. What you did see from this is that there was no apparent benefit in terms of thrombotic events and no apparent increased risk for bleeding. The effect on mortality is pending further study, and I didn't see any follow-up to this January data. So this slide, I'm trying to put together, and again, this was put together on a basis of looking at the data that I could see that was currently published. And there may be inaccuracies based on therapies that are approved based on where you are currently practicing in the world, because this list is going to differ based on the utilization authorizations of your own medical fields. So my apologies if this does not reflect the list that you are following, but I did put this together quickly. So the approved therapies are the dexamethasone, the remdesivir, the monoclonal antibodies with the recent EUA in the US for the bamlanivimab and the atezolizumab, the baricitinib, the tocilizumab, and then you have the ones that are undergoing clinical trials. That includes convalescent plasma, inhaled interferon, full dose anticoagulation, the use of ACE and ARBs, vitamin D, aspirin, colchicine, DPP-4 inhibitors, ivermectin, molnupiravir, which is the new Merck medication that received a little bit of press, systemic interferons, the bevacizumab, and the therapies with no benefit. And I know this was in the news recently, and that was a lopinavir, ritonavir, and the hydroxychloroquine and the chloroquine. And again, some of these medications are being used in part of local protocols, and I understand that. I am just trying to give you the evidence-based approach as to why we are making the recommendations that we do. Okay, sorry. There we go. So let's look at remdesivir. And I think this is the one that has probably the most press, the most long-term experience. And this is a medication that inhibits SARS-CoV-2 RNA-dependent RNA polymerase, which is essential for viral replication. The dose is 200 milligrams on day 1, followed by 100 milligrams from day 2, administered via IV infusion. It's typically used for a 5-day duration, but can be used for an additional 5 days. It's given to patients at the early stages of severe COVID with those, but it excluded those with patients who had chronic kidney disease with low GFRs. They had improved recovery times in patients on supplemental oxygen, but not in the subgroup of intubated patients, and no significant difference in mortality rates in placebo group. No substantial difference in adverse events between the remdesivir and the placebo group in terms of anemia, acute kidney injury, pyrexia, hyperglycemia, or elevated liver enzymes. So we're giving it for improved recovery times in patients on supplemental oxygen. This should not be given with patients who are on hydroxychloroquine or chloroquine because of potential drug interactions. And I write that in bold because I think it's just important to know this, because it is hydroxychloroquine and chloroquine are being used. Baricitinib. So this is an oral JAK kinase inhibitor used to treat rheumatoid arthritis. And what we're seeing now is the use of immunomodulators that have been approved for other conditions now in the use for COVID. This is dosed 4 milligrams once daily. It's a tablet for 14 days of total treatment or until the hospital discharge, whatever is first. The mediated inhibition of these kinases led to a reduced viral infectivity in people with primary liver spheroids, and it reduces levels of cytokines implicated in COVID-19 and inhibits their signaling. In patients with COVID-19 pneumonia, baricitinib treatment was associated with clinical and radiologic recovery, a rapid decline in the viral load, inflammatory markers, and IL-6 levels. So I believe at this time that this medication is currently being used commonly. And there was a New England Journal article that shows that this is used in combination for remdesivir for hospitalizations with COVID-19. And what this study from the New England Journal is showing And this showed that this combination was superior to remdesivir alone in reducing recovery time and accelerating improvement in clinical status among patients with COVID-19. And again, this is a patient population who is receiving high flow oxygen or non-invasive ventilation. So this is a more severe group that is experiencing it. And this combination was associated with fewer serious side effects. So this is where we're using this combination. So let's talk about tocilizumab. This is an IL-6 receptor antagonist. It's given as an IV of 8 milligrams per kg as a single dose with a maximum dose of 800 milligrams in combination in patients who are receiving glucocorticoids. And what they found in this study is that in hospitalized patients with COVID-19 pneumonia who are not receiving mechanical ventilation, tocilizumab reduced the likelihood of progression to the composite outcome of mechanical ventilation or death, but it did not improve survival. So the Infectious Disease Society of America recommends this should be used in addition to standard care. It should be used early in hospitalized and severe critical COVID-19 patients who are admitted to the ICU and who have elevated inflammatory markers. And I had discussed some of those inflammatory markers earlier, the D-dimer, the ferritin, the IL-6, and the CRP. And the names of the trials were the REMAP-CAP and the recovery, and they suggested that there was mortality benefit if it's given early after hospitalization and ICU admission. So you will be seeing patients who are on this, and I do know that there are patients who are receiving this right now in the United States after a review with both the critical care physicians and the pharmacy committees. This is again indicated in adult patients who are over the age of 18 with acute illness within 14 days of onset. They require oxygen, say up to like greater than 10 liters per minute, who are receiving dexamethasone or other corticosteroids. It's important to realize that it should not be given to those who have any other suspected secondary infection, bacterial, fungal, viral infection. You should not be given if they're thrombocytopenic, if they have transaminitis that are with AST or ALT 5 times upper limit of normal. They have any chance for having a gut infection with a bowel perf because of a history of diverticulitis, if they have latent TB, or if they're pregnant. Okay, so then there's bevacizumab, and this is a medication that blocks vascular endothelial growth factor, and I believe that this is used in malignancies. It's a single dose of 500 milligrams that's dissolved in 100 milliliters of saline. When compared to control, it showed by improving oxygenation and shortening oxygen support duration. So if this is used in combination with standard of care, it might be highly beneficial. And again, randomized control trials are necessary. As I move away from the severe disease, now let's talk about the monoclonal antibodies, because this was recently in the news, and this was the emergency use authorization for the combination of the bamlanivimab and the etesevimab for use in the non-hospitalized patients with mild to moderate disease. This is meant for children 12 and older and adults if they weigh more than 40 kilograms, I believe around 88 pounds. Who are greater than 65 with chronic medical conditions who are not on supplemental oxygen. And what it does is it causes a 5% reduction in hospitalization and mortality. And the reason I'm bringing up this monoclonal antibodies is that we have to differentiate where these medications are being used in the severe hospitalized or in the non-severe. But here the indication is for moderate as well. So it should be administered as soon as possible after a positive viral test and within 10 days of symptom onset. The dose that was approved, I believe they studied 2 different sets of doses, was a 700, 1400 milligram combination, and it's given together as a single IV infusions. Okay, and so here I showed that it's not indicated for hospitalized patients or who require COVID-19. Again, in the moderate category, you have another an antiviral, the RNA polymerase inhibitor, for mild to moderate COVID infection, and that's favipiravir. And this has been used extensively across the world. You can just see a few of the countries that have been listed. This has been approved for use in India since June of 2020, and it's dosed at 1,800 milligram tablets twice daily on the first day, followed by 800 milligrams twice daily up to a maximum of 14 days. I don't have any personal experience of knowing anybody that's been on this. Not sure about the efficacy of this. This also made the news recently. So I'm giving you updates that have happened within like the last week. And this is molnupiravir, which is another analog ribonucleoside, which inhibits RNA virus replication, including SARS-CoV-2. And what this drug does, it's an oral medication. It insinuates itself into the RNA of the virus. It increases the viral mutation rate, so the virus can no longer replicate. And this is currently being studied. And Merck just gave its licensing agreement to 5 generic companies within India. So you will see that this is now available. What about convalescent plasma? You hear a lot of reports about this. This is taking in the pooled plasma from people who've been infected. The issue is that you develop antibodies 2 to 6 weeks after you've been infected. What your antibodies are reflects the virus that was in the community at that time. By the time the plasma is collected, especially in a rapidly mutating environment, it may not be so efficacious. This is a form of passive immunity. The benefit is possibly from the neutralizing antibody parts. It might be beneficial if it's used earlier in the disease. If a patient has a baseline humoral immunity, which means that they have low, they're hypogammaglobulinemic, or if they have like low responses to immunizations, if you were to check titers, maybe this would be a better population to serve them with convalescent plasma. And again, this is of no benefit in severe disease. Okay, this has been very controversial, especially for rheumatoid patients that all of a sudden faced a shortage when this became in the news. But there is a complete lack of benefit in hospitalized patients. And if anything, we are subjecting our patients to side effects and toxicity, such as the prolongation of the QTc and arrhythmia. The EUA for hydroxychloroquine was revoked in June of 2020. What about interferons? Interferon beta was tested with no efficacy or no effect on the 28-day mortality rate. However, in the inhaled form, it led to increased likelihood of recovery by day 15, and that is undergoing clinical trials right now. Another medication combination, lopinavir and ritonavir, there have been clinical trials that have failed to demonstrate efficacy. Here in this particular study, again, published in the New England Journal, and this was last year, in hospitalized adult patients with severe COVID-19, no benefit was observed in the treatment beyond standard care. Now, just because these medications have not demonstrated efficacy, sometimes in a different environment in terms of a different mutated virus, it is worth relooking at all the medications and options. And I wanted to say something about ivermectin. So recently there was a case, and I believe it was in Chicago, where the judge had ordered that a patient be given ivermectin because they requested it because they felt that there was no other therapies available. Despite the opposition from all the physicians in that hospital, the ivermectin was administered. So when that had happened, the FDA came out with this guidance and why it said that you should not use ivermectin to treat or prevent COVID-19. Now, this is in the US environment. And again, this can be modified to your local environments. So it's not been approved for ivermectin in treating or preventing COVID-19 in humans. And then it goes on to what the indications are in the US. However, if you're using ivermectin for the prevention of strongyloides reactivation in those who are receiving glucocorticoids, then I think that the use of this medication should be reserved under those circumstances, and if not, additional circumstances that you have deemed necessary and local. So we have a long, long way to go. And I think that as the landscape changes of the medications that are being discussed, and before, 2 days evolve and then all of a sudden 5 drugs are in the market, I think the point I want to make with this diagram is that we need to vaccinate. And we can't forget that in the therapy of COVID-19, we need to prevent. And if we can't prevent because the virus is raging, we need to do as much as we can to make sure that the vaccines are available and are actually administered. So I hope that this was a helpful summary for those. And I apologize if there were things that I said that don't apply to you locally. I do understand that this may not be universal, but I just wanted to make sure that some of the names of the drugs and to understand what's IV, what's oral, what was used for mild, moderate, or severe disease, what's been evidence-based determined, what's under consideration was valuable to you. Thank you.
Thank you, Monica. Such a clear, precise summary of all the various options available to all of us in some countries and maybe not in others. I welcome any questions from the floor for Monica. Does anybody have any questions?
Thank you very much, Dr. Monica, for your nice presentation. It's detailed. Thank you, Mr. Chair. I'm Dr. Jamaluddin Chaudhary from Bangladesh. Just a question actually regarding the ivermectin. Actually, India has already given nod to use it, and I have seen the BCGI also approved the production of ivermectin for human use. So, in that context, actually, you are just telling us about the situation in USA. Can you just enlighten us more about ivermectin and things that's actually, it's a bit controversial here also in Bangladesh actually. In the clinical guideline, national clinical guideline, we have just revoked actually. We are not advising the people to use ivermectin. Thank you.
Yeah, so I think the reason that ivermectin was originally picked was that they thought that it had direct action against the SARS-CoV-2 virus. I think because it's an antifungal medication and we're talking about a viral infection, it was not matching. And we felt that, look, with anything that we're doing, the risk-benefit ratio is not good. I think what's concerning is that when we're giving such immune suppressive medications, we are reactivating infections in many of our patients that we don't even know that they have. So we try to treat their COVID-19, but then we reactivate in another infection. So I think that ivermectin should be made available because, especially in areas where you're having strongyloides, that's one example. But I don't know if ivermectin has a role in any of the other local infections that are being reactivated. For example, for tocilizumab, that medication really has the ability to reactivate a lot of infections. There's a strong judicious use of that medicine. In the US, there actually is a committee that decides whether or not a patient receives it. It's not just one doctor who says, okay, you can give the tocilizumab. It's actually a committee of pharmacists and doctors that get together, and then somebody has to sign off for it because it causes such immune suppression that they have to make sure that they're doing no harm. The benefit of these medications, you might see that it shortens hospitalization. You might see that it might prevent mechanical ventilation, but I don't know how much is really effective in terms of reducing mortality except for dexamethasone. So that's why I think there's so much controversy is what is the risks and benefits. And I think the world really got a lesson after the hydroxychloroquine story. And I think this is just a continuation of that.
Can I know more from Indian side? It's why the Indian government has approved the use of ivermectin in COVID-19. Can I get an update from if anybody?
Dr. Pillai, maybe Dr. Pillai can, or Dr. Minashi, any idea?
Yes, so the efficacy per se, I mean, we would say that there are some studies in the Indian setting that are showing some sort of, reduced duration of illness when you're taking ivermectin. And there is, I'm sorry, I'm not, I don't remember the exact pathway, but there is a certain amount of, antiviral properties that this antiparasitic drug does have, and which is why this has been approved in the Indian setting. I wish I knew more. I promise to come back with a little more specific, mechanism of action of this drug in the next session around, and we could probably have a better discussion. But yes, there is an antiviral property to the drug, and that is why we are using it. 300 micrograms per kg body weight is allowed, and that's what we are giving. We're giving it for, on a once daily regimen for 3 days in the initial stages of the disease. So if the patient is coming to us later than day 6, day 7, then we don't think it's going to be effective. Just like Dr. Monica said, a lot of these drugs we can sort of give it in the earlier stage, but in the later stage, I mean, the mainstay of treatment still remains dexamethasone and equivalent drugs, right? So that's what it's even being used as a preventive medicine. People are taking it once weekly. The healthcare workers are taking it once weekly to sort of prevent them from having a severe disease. But I mean, obviously it warrants more studies, and I think that's what I can say about it right now. And probably the next week we can, have a short 10-minute discussion on ivermectin.
I'd like
Thank
to
you.
actually share my screen again, because there is a study that I just found here about the chemoprophylaxis of the use of ivermectin. So this is a study that was published February 16th, 2021 on the online portal of PLOS ONE. I don't know where these authors are from, but what they're showing is the role of ivermectin in the prevention of SARS-CoV-2 infection among healthcare workers in India. Are you able to see my screen?
Yeah.
Yes, yeah.
Okay, so what it shows here is that a 2-dose ivermectin prophylaxis at a dose of 300 micrograms per kg with a gap of 72 hours was associated with a 73% reduction of infection among healthcare workers. So this is the chemoprophylaxis use that she is talking about. This was conducted as a hospital-based matched case control study among healthcare workers in Bhubaneswar, India, between September to October 20th. It looked like there were 76 controls and 41 cases. And then that's how it was. So, I mean, that's a small study that shows you the one role of ivermectin in India.
Dr. Monica, actually, WHO just conducted just research on it, and they formed a committee. That's committee appointed. Actually, this is no use actually, because they were telling they have taken the data from Bangladesh also. It was bigger in Bangladesh. That was actually sample size was more than 400, but it didn't give any proven efficacy. So WHO actually had just appointed that no ivermectin till the bigger trial is going on. So the results coming up from bigger trial. So they have just appointed in March 31 latest. So I don't know why. That is why I'm just asking whether India has had a bigger sample size in the research, but it's very small. The 70 in Bangladesh. Yeah.
The particular study that Dr. Monica has just showed us, yes, that is a pretty small sample size. We do not have, bigger studies, and I think that's where we are sort of behind. But yes, as I said, probably next week we can have a good 10-minute discussion on ivermectin itself and whether or not this could be helpful in preventing severe disease. I just wanted to ask another question to move on from the topic of ivermectin to Dr. Monica. And this is about plasma. So there's a big hullabaloo in India about plasma. So as soon as the patient gets serious, the doctors pretty much tell the patients, the patient party, so to say, that plasma is needed. And there's this whole demand and supply, sort of racket going on, and the patients are really in despair, and they think this is the only, sort of solution that they have in front of them, barring tocilizumab and all those other expensive drugs. So I just wanted your input on it, since the is this, you just said that this is not something that would be helpful in the severe disease. So if you can just throw some light on that, that would be really beneficial to all the viewers. And I just wanted to know, you are still trying to share the screen, right?
Oh yeah, I can unshare.
Yeah, if you want, I can.
There we go. Okay, yeah, so the convalescent plasma was in the case of the mechanically ventilated patient and the severe COVID patient. However, if it's used early in the course of the disease for milder to moderate symptoms, I do think that there's a role. But I also think that the value of the convalescent plasma also is related to the viral properties. If the virus is mutated and you don't have a humoral response, your plasma is already 6 weeks old. It represents the virus that was circulating 6 weeks ago. So I think that the efficacy point is a moving target. So it's a moving target in terms of where are the donors coming from, how much of a humoral response the donors are. Are they young donors, or do they have immune senescence and they're older donors? I also think it depends on which point of the time course that you are receiving this. But most of the larger trials, maybe we're looking at more sick patients, and that's why we didn't see the benefit.
Thank you. I just want to direct the query from Angelique. But before that, just a quick one. I was just looking at my notes that I took when Dr. Agarwal presented. I remember the ivermectin action was in the replication of the viral RNA at the ribosomes, when the large polypeptides chains were cleaved by a couple of proteases, and one of them is acted on by ivermectin, apparently. So, Angelique, you have a question? Angelique,
good morning,
are you there?
and thank you. Yeah, good morning, and thank you, Monica, for this excellent presentation. I want to, it's not so much a question, but an observation. So in our surgery for the past 3 years, we are doing routinely SATs monitoring on each and every patient coming in. So we're so used to the SATs, and I've got a bit of a problem with the SATs guidelines, because what we have seen in the surgery is that the average patient's SATs is not above 96, but most of the times, you know, a healthy patient and the SATs is 92% or 90%, and after they lie a few minutes on the bed, it starts to improve. And we saw that it is most of the times related to them not breathing properly, you know, a bit of anxiousness coming to the doctor. So I just want to caution that we should not, if a patient's SATs is 92 or 90%, and they're actually fine, and you can see that they are breathing, I always call it shallow breathing, like a little bird that's not breathing properly. And just want to caution, so that you don't think that patient needs oxygen and being admitted to the hospital. So just to take the clinical picture into consideration. Thanks.
Thank you, Angelique. Any other questions from the floor, Dr. D'Souza?
Yeah, this is Russell D'Souza from Melbourne. Monica, thank you very much for that very enlightening talk. I just wanted to move to another area. We in Australia have recently had a spate of the clotting from the vaccine, the AstraZeneca. We, as you know, here we are for 50 and above. We have only one vaccine that's available, and that's the AstraZeneca. Now they've started. Initially, it was going on phase. You know, you had only the vulnerable people and the healthcare. Then there were some problems, and so now 15 above, they've opened it up fully for the AstraZeneca, and now we've had about 5 or 6 of these clotting problems, and people are being admitted. I just wanted your thoughts about prophylactic, blood thinners and all this. I remember once before we were talking about looking at the C-reactive protein, and if it was above 1, we were using starting an anti-inflammatory for before you start the vaccine. And I've done that a couple of times for some of the patients whose CRP was above 1, as KK had advised. What's your thoughts about this, Monica, in terms of prophylactic or use of, the thinners of coagulation, or that people are now become very hesitant because after seeing the hospital, 5 cases or 6 cases have come up and it's been advertised and, in hospital. So there's a lot of hesitancy. So I'm just wondering.
This is a big topic, right? Because as we start to immunize the very aggressive and the very highly motivated citizens with the vaccine, we're now hitting the citizen population where there's hesitancy and who are in the gray zone. Should I or should I not get the vaccine? Those who wanted to get the vaccine already got it. And so one of the biggest issues is that as these vaccines have been around, it's not just the AstraZeneca that you have, but you also had the Johnson & Johnson pause by the FDA in the United States. And again, it was a clotting issue. I would have been very in favor of utilizing anticoagulation of some sort, or doing a coagulation workup prior to a vaccine if I was concerned about it, especially if there could have been risk factors for it. But in the setting of the Johnson & Johnson vaccine, when they had the central venous sinus thrombosis and when they had the issues related to anticoagulation for those patients, we now have a scenario where you're having 2 types of blood conditions, one that requires anticoagulation and one where anticoagulation is not recommended. Again, I do understand that this is the AstraZeneca versus the Johnson & Johnson. They're totally different scenarios. But that just raises the point that are we going to be doing more harm than good, especially for something that has such a low frequency, right? When we are giving regular immunizations, multiple immunizations to our children in our pediatric clinics, they have a much higher rate of an adverse reaction at a general level than we are getting to these COVID vaccines. It's just that they're being much more publicized. We have much more rates of thrombotic events with oral contraception, with people who smoke. But I get it. Like, we want these people who are very, very careful, who are electing to get vaccinated, to be on anticoagulation. I don't know if there's a good answer. If there was an easy answer, then these companies themselves would have recommended it. Yeah, I would say that if there's any issues, then make sure that if they're worried, make sure they get their vaccine in the morning, make sure it's in a hospital-based facility, and make sure that they're observed the whole day. And you intervene early if there's any concern.
Yes. Thank you, Monica.
Thank
That's
you.
a very good reply. Yeah. Any other questions from the floor?
Yeah, thank you, Chair. Monica, it's excellent presentation. I just wanted to know more about nebulization therapy. Can you just explain some more? Thank you.
So nebulization, or the aerosolization of a medication, whether it be budesonide, whether it be salbutamol, whether it be ipratropium, is done through a nebulizer device to aid in bronchodilation. And in the process of nebulization, you're either using a T2 piece or you're using a face mask. And what happens with the nebulization is that you have aerosolization of the person breathing and coughing into their piece, and they're coughing out what is being inhaled. So for example, if you're using a salbutamol and you cause bronchodilation, you're mobilizing secretions, a person wants to cough up, they're coughing directly into the device, and then they're aerosolizing the spread. You're more likely to aerosolize with a nebulizer than you are with an HFA inhaler that's used with a spacer. And so therefore, at least in our clinical setups, we have not been allowed to use any nebulizers, and we've just replaced everything with the inhaler device.
Yes, thank you. But it's interesting, in the early days of COVID, just to share, one of our major hospitals here, we had a patient that we didn't know had COVID in the early days of COVID in Singapore. And this patient was nebulized, intubated, and about 100 healthcare workers were all exposed to this particular patient. Everybody wasn't wearing N95. Everybody just wore a surgical mask and nobody got infected. So just anecdotally, just to let you know, this is what happened in Singapore. Thank you.
What about the condition in Singapore now? You see, We were just watching the last week.
okay.
Mm.
Yeah, just to update everyone, since you asked, Dr. Chowdhury, we initially started, the whole hullabaloo started on the 28th of April, and we discovered a big cluster at one of our major hospitals. The hospital has about 15,000 staff, 1,700 beds, monster hospital here, and it's called Tan Tock Seng Hospital. And in the first few days, there were about 16 cases, 9 cases a day, 9 cases, 14. Now it's dropped to 4, 2, and 1 case in the last 3 days. So 7 cases in the last 3 days. So I think we're getting the situation under control. But we've announced a mini lockdown on a 5th of May. And that means border controls, worship, funerals, restrictions, gyms are closed, and the social gatherings have been reduced from 8 to 5. You know, used to be able to go out for dinner for 8 of us, now it's 5 of us. And then, yeah, a whole bunch of restrictions and mandatory use of our Trace Together app. I think I remember I showed it to you all last week. It is an app that looks something like this. That we all use. About 4.7 million of us are using it. This has been very, very powerful because this has allowed us to ring fence very, very effectively the population and the people who are exposed. So if you've been to a place where there was a COVID patient walking around, it will tell you that you've been in that place. And then so it's been very, very effective, this use of technology. And
Dr.
I
Charles,
think, yes.
just another question actually to Dr. Monica. Monica, you are just mentioning about the molnupiravir, which is termed as a molnupiravir also. So, but it's a promising drug, they're telling. And but the question is, its mechanism of action is the mutation of virus, actually continuous mutation. So they are they're anxious regarding the mutation event may take place in the human body also. Do you have any information regarding this? Dr. Monica, you're muted.
Sorry. I think that the mutation is only affecting the virus particles and not to the human, but I don't know exactly the exact answer to your question.
Okay, thank you.
Any other questions from the floor? If not, we're almost coming to the end of our hourly session on Zoom.
Yeah, we are sorry, actually, just to know, because I didn't join the beginning. So what about the condition of how the president actually can just be updated? President CMAAO, Dr. Agarwal.
Dr. Monica, you'd like to take that?
Yes.
Sure. He is currently stable, and we're just hoping for continued recovery. Yes.
Thanks. Thanks. Thank you.
I think
we're comment by Dr. Pillai.
Yes, Dr. Pillai.
Monica's briefing was very useful, and the polypharmacy definitely has to be avoided, particularly because the virus affects many of the organs, and so the complications also can be high. And this the gold standard treatment he already mentioned steroids and anticoagulants. But the only thing is we have to start it sufficiently early. So now the protocol is that if you are mildly symptomatic, home care is enough. But then any worsening of such patients, unless we do blood tests or oxygen saturation, we can miss it. And all the drugs, antiviral drugs, whichever is available, steroids and anticoagulants, has to be started early in the protocol so that you can save life. So that again is very important. And as has been pointed out, high flow oxygen or non-invasive ventilation both does save life. But once the patient requires intubation and positive pressure ventilation, very few of those patients we are able to save. So the emphasis has to be continuous vigil regarding early complication and initiation of treatment at the earliest. And one question I would like to ask Monica is the oral anticoagulants like Eliquis or Apixaban. What is its role? Can we initiate that in the early period of treatment itself? Because the low molecular heparin definitely does reduce platelets and thrombotic episodes, particularly autoimmune thrombotic episodes, are much more common when we use such drugs. Thank you.
Thank you, Dr. Pillai.
I would just like to add here, we at Dr. K.K. Agarwal's team, we have modified the word early to timely. So timely administration of steroids and anticoagulation is the key. There is a question in the chat box which is asking what is the best treatment for critical COVID. I congratulate Dr. Monica Vasudev for a beautiful and brilliant presentation. It clearly runs in the family. Teaching clearly runs in the family. And yes, so the best treatment I would say would be the timely administration of steroids. It has to be decided by the clinician what is the right time and who actually needs those steroids and who does require the anticoagulants. I would hand it over to the chair to close the meeting. I think that's all from us.
Thank you very much. And actually, before we close the meeting, we all like to say some words to our president, who's probably watching us from his wherever he is. And Sarab, shall we just ask everybody to say a few words? How does that
so
work?
I would request, so what we are doing is we are probably trying to, we will do that, I think in the non-live session. So we will close the live session before. So I would like you to first, give the closing statement. And I thank you, Dr. Monica Vasudev, to be here. And without her permission, I'm asking her to be here for all the sessions till the time Dr. KK is not there, and after the sessions also. And I would also invite few more speakers, if I can, to make this more, viable discussion. And I think it's already going on. The only point is that Dr. KK, when he comes back, we want all these speakers to be in and around. It's not that they are only here for that time. So I will now let Dr. Chong to do the closing statement.
Thank you very much, everyone, for this, for joining us on our 57th session. It's been an amazing marathon of sessions. I mean, week after week after week, and all, I must say, was driven by our president, whose energy levels is boundless and unlimited. And we're so sorry that he's unwell at this point in time, but I'm sure he will recover and he'll bounce back and he'll be as lively as he always is. And he's really been a great force in driving these sessions, these weekly sessions where we've benefited so much. Without much further ado, I'd like to thank Dr. Monica Vasudev again for her very enlightening presentation on the latest roundup of all the various treatments for especially severe COVID infections, especially those who are hospitalized in ICU. And without much further ado, I look forward to all of you coming back next week to join us again for this this marathon series of awesomely enlightening sessions. Thank you all, and good luck and Godspeed. Thank you.
Thank you.
Thank you.
Thank you,
Let us
thank you,
pray
sir.
for KK's early recovery.
Thank you very much.
Thank you.
Thank you.